Well, thank you very much for the opportunity to present. I will admit I may have gone and self-edited the conference schedule to save this date for myself, but that's neither here nor there. Really sort of two main objectives for today. First would be to give a plug for the MSCR program. I had just a wonderful experience, and I think it's a great use of the research time that we have. And then also to give you a little information about the project I've been working on for really the better part of 2 years now. And we'll go from there. So my path to the MSCR program really has to do with two individuals, Dan Rafai and Praveen Mumineni, which if you would have asked me when I started residency, who would be the two people who would lead me to, arguably the most important academic experience I've had to date, I don't know that I even knew who either of these people were at that time, but really both of them were quite instrumental. So first, October 2014, I was on my Midtown rotation. I had a great realization I wanted to do spinal neurosurgery. It was really a fantastic time, and kind of realized, all right, if I want to get things going, I'm going to have to start doing some research projects, especially in spine. Dr. Rafai had a project he had been working on.
Griff, are you not going to back it up a year when you swore to me that
you started at the beginning when you swore you were going to.
When I reserved a spot for you.
Well,
did that get edited out of your talk?
That did get edited out, yes. Just a little bit
That's
of
your right to do so.
Exactly. We call this revisionist history. We're in the midst of.
Obviously, still sensitive.
Very.
Why I lost the 2016 election?
Yeah. Several factors at play. So Dr. Rafai asked me if I was interested in helping with the project. I said yes. I was at the point where I would say pretty much yes to anything. And as I started working on it and he started asking, when am I going to see some results? When am I going to see some results? I slowly started admitting to myself, I really don't quite know what I'm doing here. And there were questions that I would continually ask that I was hoping someone would help with. Some of these research analysts who I'll reference later, or biostatisticians, and really, depending on others to try and get the work done was just not going to be a sustainable solution. At the same time, I was looking for a spine fellowship and had a phone interview set up with Dr. Mumineni. And, I contributed a little bit in the conversation, but mostly heard a lot about their clinical research efforts and heard about a lot of their studies through the ISSG with propensity score matching and the different trial designs that they were investigating. And that's really when I thought, oh my God, I have no clue what I'm doing at all. So I'm sitting here while he's talking about all the different studies with the ISSG, and I literally am Googling as fast as I can. How can I figure out what the hell I'm doing? And here's what I found. So I started doing a little bit more investigation and looked into the MSCR program, and I'll give you a little bit of an overview. So the MSCR is based with the Georgia CTSA. It used to be called the ACTSI, but recently rebranded. It's a clinical and translational science alliance between 4 main sites: Emory, Georgia Tech, Morehouse, and University of Georgia. And we're one of 50 national sites with really 3 main aims. One would be to train the next generation of clinical investigators. That's the one I primarily benefited from with the MSCR program. Translate lab discoveries into treatments for patient and engage communities in clinical research efforts. And this is an NIH-funded grant that Emory was one of the first core sites that they've now been continually funded for several years. So the MSCR program is a degree program offered through the graduate school. It's not through the medical school. And the mission statement is that it provides innovative didactic and mentored research training to those interested in pursuing a career in clinical and or translational research. And there's 3 main funding mechanisms: the TL1, the KL2, and then the MSCR program. Kelly Bajanki, who is a PhD and assistant professor, started working in the Willie Lab. She was my classmate, and she was going through the KL2 funding mechanism. So there's a pretty intense didactic curriculum. The first semester, just a little bit of light reading in the introduction to clinical and translational research, analytic methods, which is essentially epidemiology, biostats, data management using SAS, advanced data management using R, and then some other electives. The second semester had a continuation of the epidemiology course, analysis of clinical research data, bioinformatics with high dimensional data analysis, looking at a lot of the big data studies that are going on right now, clinical trial design, a colloquium, some ethics, and then a scientific and grant writing course. And then through the whole time, there's several other projects that you're always going to have to be working on. The mentored thesis, which is the results of which I'll present today, journal club, an IRB rotation, as well as a clinical research network rotation. So really finding a way to explore all the different research opportunities here at Emory. The research thesis is a proposal and a mentoring team that are actually required to apply and get into the program from the start. You spend the first 2 semesters really refining the project with all the things that you're learning in the coursework. And then a dissertation level product is expected by the end of your 3rd semester with the thesis defense in the early semester 4. So I really have just completed this in the last month or 2. The application process is onerous, to say the least. There's a new online submission system which was not there when I applied. But you have to have a cover page and a personal statement. You have to have your own biosketch. You have to have the biosketch of your lead mentor, as well as all the co-mentors and advisory committee. You have to have an NIH quality submission for a human subjects research project with an abstract, a specific aims that can only be 1 page. And I only put that up there as sort of tongue-in-cheek because I went back and forth so many times to them about how do you put all this stuff on 1 page? And you got to play with the margins, you got to change the font, you got to bold and italicize. I'm like, guys, this is so not what is important here. And they're like, this is the most important thing. So, the things you learn, I guess, when you get out of the operating room. You need to have 3 to 5 letters of recommendation, a letter of protection, which is sort of ironic, from your clinical chair or program director saying, we've committed to allow this person to do this work and we won't pull them out and make them, cover vacation or do that or this or that or the other thing. And then, to throw an extra on top, you also have to include an application fee, which I guess everything in life costs money. The lead mentor really is the most important part of the application. So they want an established, independently funded researcher with a strong mentoring track record. You have to have active federal funding. You can only mentor a single MSCR applicant. And any supplemental mentors must have representation from one of the other CTSA sites, so primarily to prevent people from having someone from Harvard and University of Chicago and all over the place. So the selection process, the applications are due the April of the year of matriculation, and all of the executive committee members form essentially an NIH study section and go through everyone's application and everyone's research proposal. And the main selection criteria, the potential of the candidate to develop into a successful investigator, evidence of commitment on part of the lead mentor and mentoring team, the quality and feasibility of the research project, and then a 4th criteria, which is diversity to encourage training of applicants and candidates from different departments and underrepresented minority groups. I have it on good authority that this is pretty much the only reason that I was admitted to the program. That we had no one at the time, Juan Marco wasn't a member of the department yet, who had done this program. And they said, oh, yeah, might be neat to have someone from neurosurgery. We've never done that before. I guess we could give it a try. So it's good to know that I was an experiment. I guess the underrepresented minority group would be bald white men, so I'm not sure how well that worked out for them. But so the application process, I found the program in October of 2015. I essentially started right away. And I mean, literally took me until March 23rd, 2016 to get everything together, collated, formatted appropriately, and submitted. I waited and waited and waited, and finally, despite questions from Dr. Ashiku and my co-residents about what are you going to do next year, I finally get this letter on June 3rd. Says, congratulations, we've accepted you in the program, contingent on you revising your project, and oh, by the way, final decisions regarding a tuition scholarship are pending because we're not sure exactly how much money we're going to get. So stay tuned on that. I'm like, all right, well, that's interesting. I already have a ridiculous amount of loans from undergrad and medical school. I'm not really sure I want to throw an additional 2 years of graduate school on top of that. And so 7 weeks later and 3 days prior to the start of the program, I finally get an email. Oh yeah, you'll get a tuition scholarship. Sorry for not telling you sooner. Don't worry about it. I'm like, all right, well, I guess we're going to get started. And 20 months later, I guess the rest is revisionist history. And so this is my project, comparison of DRGs and CPTs for cost analysis in spine surgery. So a little bit of background and rationale. As we know, neck and back problems are incredibly common. In fact, if you look at the epidemiology, not just surgical back and neck problems, but as a whole, 80% of Americans are estimated to seek care at some point in their lives for a neck or back related chief complaint of their primary care doctor. So not only are they common, but they're actually a huge source of healthcare expenditures. And over this study period of 1996 to 2013, looking at U.S. spending on personal health care, $88 billion was spent on neck and back care. And again, that's not just surgical care. That includes CT scans, x-rays, physical therapy, injections, things like that. But take note, I mean, this is the second highest source of healthcare spending in the United States. Number one was diabetes care, which obviously is, the prevalence is massive. But neck and back, spine care is the number two source of spending. And so as administrators and government officials are looking for ways to decrease healthcare expenditures, they're going to go for the biggest slice of the pie, and we're number two. So it leads to some important questions. Why are these things so expensive? What specifically leads to these costs? And in turn, how can we track and reduce these costs? So some more background. I mean, hospitals estimate costs using diagnosis-related groups. These were developed in the 1980s at Yale by two MPHs, and they were actually developed in conjunction with CMS, primarily with the goal of having a predicted resource utilization for particular diagnoses and patient comorbidities. So each patient, when they come into the hospital, is assigned an ICD code. And then all of these encounters are then grouped based on procedures performed, patient-specific comorbidities, as well as complications. And so there's different levels at each subgroup that then explain each of those things. So each DRG is associated with an expected cost and resource utilization. And in turn, as hospitals are now attempting to obtain bundled payments and upfront reimbursement, this is what they're using. And so DRGs may be all well and good, but unfortunately, each DRG may include a very wide range of patient types, diagnoses, indications for surgery, as well as surgical procedures performed. And so when you're looking for a classification scheme that is surgery-specific or surgeon-specific, it's really inadequate. So what are some other options? Well, CPT codes are an option. They're primarily aimed at the provider level cost and charges, very familiar to us. They were developed, copyright protected by the AMA. They're put out yearly. They essentially serve as a publishing house, and it's a set of 5-digit codes. They describe a procedure, a technique, a service performed, and the purpose is to map an RVU to the services rendered to aid in the compensation and reimbursement of the provider. I mean, that's why these things exist. So these codes can be used alone, so a single 5-digit code, or they can be used in combination to describe multiple procedures or multiple techniques within a procedure. And really this universal familiarity with CPT codes by providers makes it an attractive option for cost analysis. So again, going back to our key questions, our project primarily looked at how can we track and predict costs in such a way that is specific for surgeons and specific for spine surgery. So our working hypothesis was that a CPT-based categorization model will better predict total costs in spine surgery when compared with a diagnosis-related group model. And so specifically, we aim to estimate an association between DRGs and total cost, estimate an association between CPTs and the total cost, and then compare the ability of DRGs and CPTs to predict total cost in spine surgery. So we performed a retrospective cohort study from a single institution. We had IRB approval. We looked at fiscal years 2012 through 2016. All patients undergoing a spine surgical procedure, so no injections or radiofrequency ablation, all spine surgeries within our system. So that includes Emory University Hospital, Emory Orthopedics and Spine Hospital, as well as Emory University Hospital Midtown. This also included spine surgeons from neurosurgery and orthopedic surgery training backgrounds, which was, honestly novel compared to a lot of the studies that are in the literature. Our inclusion criteria were that we had adult patients over 18, diagnosis requiring a spine surgical procedure, and inpatient spine surgery. So we specifically excluded anyone who had a 23-hour stay or less. And the purpose would be is that they would not have a DRG associated because they would not have an inpatient stay. And then we also needed to have complete provider billing data from the surgical procedure to be able to calculate our CPT surgical category. And essentially, these are just the mirror of our inclusion criteria. This is our flow chart, and we'll look at specific numbers in just a second. The data sets we used were the Emory electronic medical record as well as the Emory financial accounting record. So we were able to pull these from the database. We used the patient financial encounter ID as the linking variable across the data sets. We had dates of admission and discharge, the MSDRG category, CPT codes, total costs, as well as total direct costs.
Did you look at costs or charges?
Cost. Actual costs.
How did you determine that? Are you going to talk about that?
Yeah, so they're present in the accounting system. So these patients have been discharged, so we know exactly what their costs were. It's from the hospital charge master. Everything that the patient utilized during their stay was added up and then totaled. Interestingly enough,
You also look at the charges?
so we did. There was charge data in the data set, and it's unclear. I didn't really investigate this, but not all patients have the total charges, and I just played around with them. There's not a clear 4-to-1, 4x multiplier, whatever multiplier. There is some data about what kind of insurance patients had, so I'm sure we could investigate and try and understand that, but that wasn't readily available or offered from the financial folks when we got the data set. Yeah, so this was cost. This is actual expenditures. So there were issues with CPT codes. While there's one DRG per encounter, a patient could have many CPT codes per hospital stay. So CPT codes not just for the surgery, but CPT codes for the hospitalist and CPT codes for radiologists and everything like that. So how best can we use the CPTs to describe the relevant surgical procedure, especially the spine surgical procedure? And likewise, how can we condense many CPTs into a single datum to be used in our analysis? And so Dr. Rafai and others developed this CPT-based surgical category. And it's based on essentially just filtering logic, common coding combinations for reimbursement for particular spine surgical operations. And so it breaks down like this, a number for each region, cervical, thoracic, and lumbar, a letter for the relative location, and then subsequent Roman numeral modifiers looking at increasing number of segments as well as a technique specific to a non-fusion procedure. So just some examples, if we were going to look at cervical anterior fusion 1 to 3 segments, you could have many different combinations, 22551, 22845, but not 22552, or 22554, 22585, and 22845, which initially when we first got the data and when I started working on the project in 2014, this had sort of been started by one of the guys in the the healthcare quality center, and he had written some code, but it wasn't complete, and there were some changes with CPT codes. So really, without the MSCR program and learning how to do some basic programming in R, there's no way I could have ever written this logic to be able to figure this out. Again, same concept for a thoracic anterior and posterior 360 fusion, looking at 3 to 6 segments, 7 to 12, 13 and up. And then a lumbar posterior non-fusion, discectomy, laminectomy, and if it falls into any fusion categories, then it would be excluded. Like I mentioned, the primary outcome measure was total cost, and the main variables were the MSDRG category as well as the CPT category, which we abbreviated CSC. All the analysis I did in R using RStudio, and again, I would put in a huge plug for anyone who's at a point where they would be interested in learning a new statistical package. This is not just for data analysis, this is for data cleaning, this is for data management, and the things that you can do with a couple lines of code far surpass, any other package. Most people use SAS because they're used to it. I think R is so much better, and so it was key for my ability to finish this project.
Okay, I'm going to ask for the old guys, what is R?
So that's a good question. So R is a statistical package. It's open sourced, and It's a worldwide sort of collaborative effort based on computer programmers as well as biostatisticians. And so the actual bare bones program, you just download it, and as long as you know the programming language, which is called R, you can do whatever you want. It just spits out results. R Studio is a aftermarket add-on that gives you a graphical user interface. And so as you add in all these different packages, these are all software packages built for R. And so like dplyr and tidyr, people said, well, I don't like the way that Excel manages my data and it's too hard, and I don't like the way that SAS does it either. So they've created this new like vectorized system where data is transformed into a little packet, and then the way that you manipulate it, it still preserves all the data, but you can cut it and slice it and concatenate it and do all these different things. And so same thing, ggplot. I mean, all the graphics I made for this, which are pretty basic, you can go through and just plug in as you're going.
Whoever's got their microphone on, we can hear you.
Fixed. So I started with an exploratory graphical analysis and then looked for some outliers. And though you would think that they wouldn't be there, it's interesting for hospital charge data. There were negative numbers. There were numbers that were in the millions and billions of dollars. Obviously, these are mistakes, but you sort of wonder if all this stuff is supposed to be automated, how's the patient getting charged a negative amount of money? At least didn't make much sense to me. Did some basic statistics, and then really since we knew we were going to have a robust data set, I thought it was important that we do a training and validation set so that we prove that all the data, all the information is going to be applicable to a secondary data set if necessary. We then used just a basic linear regression, looking at total cost versus DRG as well as total cost versus the CSC. And then we also combined them to see if there was an additive component of CSC to the DRG model. We looked for the adjusted R squared. We looked for the correlation between predicted and actual total cost, and then several other parameters, AIC, BIC, min-max, as well as the mean absolute percentage error. And our alpha was 0.05. So here's what we found. We had a total of 9,000 plus encounters in the data set. So pretty big number. Unfortunately, almost 2,000 had missing data, so those were excluded. We also excluded patients who had duplicate regions or CPT categories. So essentially someone came in and they had a neck surgery as well as a low back surgery in the same admission. That patient was excluded because the thought would be you wouldn't know exactly which to map to, and the total cost would be double for a single procedure. So we wanted to keep things simple. And then 97 patients had illogical or extreme cost data. I'm talking about millions, billions of dollars or negative values. And so we had a total of 5,020 encounters included for our analysis. Here was our distribution of total costs, and as would be expected, there is definitely a skew when you look at total costs. So performing a log transform really makes it much more normal and allows for more maintenance of a lot of the key frequentist statistic assumptions. So we worked with that. And like I just said, the log total cost was less skewed and would be better to use. Here are the DRGs that we included, 453 through 520. And for those who are not familiar, you can really start to appreciate just how general these categories are. So look at the difference between 453 and 454. Combined anterior and posterior spinal fusion. With major complication or comorbidity or with complication or comorbidity. So there's the difference in major, but that could be cervical, thoracic, lumbar. It could be for an infection. It could be for a deformity. It could be for trauma. There could be many different reasons. And so there's a lot of information that's lost in using these DRGs that are grouped essentially only based on expected resource utilization. Here are the CPTs we used. And again, there were far more CPTs than there were DRGs. And again, for those who are not familiar, each CPT can refer to either a whole operation or just a particular technique. So look at 22843, for example, posterior segmental instrumentation, 7 to 12 vertebral segments. This is an add-on code, and if you just had it, in isolation, you wouldn't exactly, know what this was referring to or what kind of operation it was using. You would assume a deformity just based on the number of levels, but again, there's a lot of missing information. When we look at some box plots of total cost and DRG versus CSC, the first graph, you can see that, again, there's quite a bit of variability within certain key categories. So again, 453, 456, 457, there's quite a range. But if we start to look at the CPTs, a logical flow begins to emerge. And so you can see, at least in the cervical categories, which are everything that starts with 1, 1A would be anterior cervical, and again, there's an increase from 1A1 to 1A2, as you would expect for increasing number of levels. For 1B1 to 1B2, again, posterior, increasing a median cost based on the number of levels. Once you get to 1C, it goes up dramatically because, again, you're doing an anterior and posterior fusion. So you have to imagine that there's going to be a longer length of stay, more hardware, more costs associated. And then D begins to drop again when you're looking at just a decompression or a laminoplasty. And this remains true as you go through for cervical to thoracic as well as to lumbar. So kind of as we knew going into this, but it finally proved with our data, there's considerable variability within multiple DRG subgroups. And the CSCs really allow for better understanding of increases in median costs as well as the related variability. So if we look just at the DRGs again, out of those 5,020 that were in a total of 16, 3,300 plus were from only 3 DRGs. So essentially 67% of the cases came from 18% of the categories. So really an overrepresentation and a bias of the data using DRGs. Interestingly, the median total cost per DRG was $22,320. The largest DRG was 456, total cost of $64,000, and the smallest was DRG 491, $10,205. Again, off the top of your head, you just have no idea what 456 or 491 would be, so it's sort of meaningless. You're just like, okay, well, these are numbers explaining some other number. Yeah.
Can you just help me explain real quick the word cost? Are we talking about what the patient is billed, what it costs the hospital?
What it costs the hospital.
Okay, thank
Yeah, what it costs the hospital.
Hey, Griffin.
Yep.
Sorry, so a while back you had said you had normalized all the cost, or you had log transformed all the cost data to make them normal.
Correct.
But like your box plots are median and
Yeah.
IQR, all this is median and IQR. So how come you're presenting median and IQR if you normalize them?
So essentially, the model, the outcome has been log transformed, right? But you can still do descriptive statistics, not log transformed.
So you use normalized data when you do your regression, is what you're saying?
Correct. Correct. Exactly right. So looking at CPTs, so 17,640 CPT codes from 29 different categories. So essentially that averages out to be about 3 to 4 codes per operation, which is what you would expect. The most frequent codes were for lumbar arthrodesis, single level, posterior non-segmental instrumentation, cage placement, additional decompression levels. So again, things that sort of make sense off the top of your head if you're a surgeon, but proving it with the data. So despite the large number of codes, there's not a lot of useful information that comes from each individual code. And so it's really the combination that proves to be unique. So when you start to split it up into the categories, 14,000 or so cervical operations in 8 different categories, 358 thoracic in 11 categories, and 3,229 in the lumbar categories. The median total cost for a cervical operation was $15,000. And the anterior fusions, 1A1 and 1A2, accounted for 56% of the total cervical operations. The most expensive cervical operation was an anterior posterior fusion, again, what you would expect, with a median total cost of $37,000. Out of the thoracic operations, 11 total categories, median cost $32,000. The posterior fusions were overwhelming the majority of thoracic operations, as you would expect. And the most expensive was a 7 to 12 level posterior fusion, $67,000. In the lumbar operations, 11 total categories, median total cost was $24,000. 1,500 posterior fusion operations, which was about 50%, and about 1,100 posterior decompressions, which you can see just doing a decompression alone really does save quite a bit of money, with a median total cost of about $9,300 to looking at fusion versus non-fusion. 65% of the total operations were fusion, with 35 being non-fusion decompression operations. And the median total cost for a fusion is $25,000. The median total cost for non-fusion is $14,000. So again, showing that by not fusing the patient, by saving on the implants and the bone and everything like that, there really is a significant cost saving. These things cost money, and we've proved it. So looking at the model, we split it into the training and validation set, 70% for the model, 30% for validation. Ended up being about $3,500 for the initial training and $1,500. And this was our model. So again, looking at the intercept, which would be the estimated log total cost for the reference group, which for the MSDRGs was 453, essentially the first in line. And then each beta would be the estimated difference of the log total cost when compared with the log total cost of the reference group. And then if you wanted to look at the ratio, you could exponentiate each of the betas later if you needed to. So there were 16 total MSDRGs, so we expected 15 coefficients plus an intercept. All but 2 of the coefficients were statistically significant. The adjusted R squared for the log total cost of MSDRG model was 0.65, and the AIC and BIC were commensurate with that. Again, looking at the validation model, it still held. So again, the adjusted R squared was 0.61 or 0.62. So proving that the model does generalize to a secondary data set. Looking at the CSCs, it's essentially identical. The beta naught represents the estimated log total cost for the reference group, which again, first in line was 1A1, cervical anterior fusion 1 level. And then each of the betas represented the estimated difference of the log total cost when compared to the reference group. All predictors but 1 were statistically significant. The adjusted R squared was similar, albeit a little bit less at 0.57. And in looking at the validation model, the adjusted R squared was again similar, 0.53. When we compare the linear regression models, again, a slight decrease when comparing MSDRG to the CSC, and that relationship essentially holds in the validation data sets as well. When you combine the two, however, there's a very interesting increase in the adjusted R squared up to 0.74. And when you calculate out the actual total cost, which we have, versus the predicted using the model, really MSDRG and CSC are, for all intents and purposes, identical. They're off by 0.06, but a correlation of 0.7 is quite good. But when you include the surgical procedure in the DRG model, that correlation then goes up to 0.84. So our takeaway was that essentially the MSDRGs in our mind are the gold standard, right? They've got patient-specific factors, specifically the patient comorbidities, any of the complications, major complications, baked into the model. So we know, it's the way that they were developed is that the expected costs would be essentially similar. Our CPT model performs similar, albeit not better, so really our hypothesis was essentially rejected. But it does allow for specific comparison of surgical techniques and approaches, and can also be used to divorce the patient-specific factors that are baked into the MSDRGs, and then can be used to then add them in a more meaningful way in a subsequent model in the future. So looking at the strengths and weaknesses of the project, we had a very large data set, an N of over 5,000, which is currently the largest series to date in the literature looking at cost analysis in spine surgery that is not from the nationwide inpatient sample or from MarketScan, which there's a lot of reasons why that's important. And even though it's a single center, there have been quite a few issues that have been proven with a lot of these cost studies that come from the nationwide inpatient sample, specifically related to coding errors that are then being carried forward through the analyses. It's a novel categorization method specific for spine surgery and can really be used with any pre-existing administrative data set without the need for a priori data collection. Both of these models are based on codes that are constantly changing. The problem with DRGs is that once they disappear, they're gone forever. But the CPTs, even though they may change, the meaning can still be interpreted, and the model is able to evolve over time to still allow for longitudinal data analysis, which is, I think, a really big strength. Obviously, it coming from a single center limits the generalizability, but we've got neurosurgeons, we've got orthopedic surgeons, we've got a private hospital, essentially. We've got a private emic hospital, and we have an academic hospital. And so, really, there's a good mix of patients and payer types that are all included in there. So I do think that it's better than just a single hospital study. There are several DRGs and CSCs that are underrepresented, but and it does rely on administrative databases, which, like I mentioned, there are some pretty severe concerns about the methodology and using those for research purposes.
Call Matt, Building C, first floor, lab waiting area. Call Matt, Building C, lab first floor, waiting area. Call Matt, Building C, first floor, lab waiting area.
So, what are we going to do in the future with this? This is all well and good, but what's the point, right? The Spine Value Project has been ongoing, and honestly is.
Call Matt, first building C, first floor lab waiting area. Call Matt, building C, lab first floor waiting area. Call Matt, building C, first floor lab waiting area.
So the Spine Value Project was really a surgeon-led institutional initiative, and though it was essentially a pilot project, Emory is deadly serious about finding some serious cost savings in the order of $2 to $3 million over this time span. And so there were other similar projects going on in CT surgery, orthopedics, general surgery, and our CSC model, which the first run of the analysis was done by Deloitte using MSDRGs. And after paying them their ridiculous fee and essentially getting data that we could have done ourselves, we've sort of moved on to using a model that's a little bit more intuitive for the people leading the study. Some of the targets were braces for elective spine surgery. If you've been at Midtown, you understand what that is. Essentially just giving a patient a script so they can go and get their own brace as opposed to providing it from the hospital. And that was like an immediate $500,000 of just by writing a prescription in clinic that all of a sudden just didn't need to be charged in the inpatient stay. Judicious use of BMP, use of cell saver as well as the disposables, neuromonitoring, and also trying to employ some hybrid or creative instrumentation strategies in multi-level fusion operations.
And that last one there, there's a lot of pushback. We have these conference calls we've had over the last couple of years with 25 people on the phone telling the scoliosis people to start skipping levels of screws or encouraging us to do unilateral instrumentation for like an L45 T-lift. And there's some data, but not a lot. And so people are very reluctant. But we've all tried to do that. And it's paid off.
In looking at some of the data, it's been less successful than some of the other strategies. Yeah.
So I'm just going back. Just so I understand. So that means limit the use of cell saver, limit the use of Aquamantis, limit the use of neuromonitoring.
Correct.
So do you guys have parameters on which you're choosing who gets neuromonitoring, who doesn't? Because as you know, that's extremely controversial.
Yeah, I don't use it very much, but we've made it now very specific. Like a deformity correction, you can use it. I think intramedullary spinal cord tumors, you can use it. Severe myelopathy. Otherwise, degenerative lumbar stuff, and there's no, we could argue that all day, but I mean, we're trying to cut out that kind of
And
stuff.
everyone's bought into it and follows the same.
Well, and at the same time.
Not completely, but
But
a big
you're
chunk.
saying from a medical legal standpoint, but when you as a group,
Right.
as a 15-member group say, look, we're not going to use it for these purposes, I think from a medical legal standpoint, you have a little bit more weight.
Well, you also, I don't know if it's been published yet, but Mark Hadley has done as part of this guidelines for spinal cord injury, done a complete review of the literature on this. He's going to present it at the Academy this year. I don't know if it's been published, but there just is absolutely no evidence whatsoever that there's any benefit. I mean, I'm sure I'm simplifying it. Basically, it's demonstrated that there is absolutely no evidence this provides any benefit whatsoever to monitor patients, and it's just completely overused and a huge waste of money. It's very expensive. I mean, I've got a couple of friends who become rich buying and selling companies that do neuromonitoring. Doug Kraft being one of them. They have friggin' fortune in that area. It's just unbelievable.
You presented at the CNS actually glass CNS, and the final slide basically said that you can use it if you want, but there's no data in a single indication that makes it out.
Mark's,
Yeah,
yeah.
he presented CNS.
Yeah, I don't know
I
if
happen
it's
to be there,
published,
but
but it's,
for whatever reason.
it's very well done and complete thorough review of the entire literature.
This is published.
It has been?
Yeah.
Journal of Neurosurgery.
JNS.
Yeah, I mean, even if you want to look at it from an institutional standpoint, Cell Saver used to be an in-house service provided both at EUH and Midtown. And at Midtown, it's become completely contract only because utilization dropped so much. They couldn't support actually having an in-house person. So some interesting.
So when you see that there's this huge discrepancy in cost, is the cost, let's just say, somebody has a 3-level cervical fusion as opposed to a 1-level. The costs were dramatically different.
Yes.
Is that mostly driven by the CPT codes, or is it driven by the hospital costs?
Yeah.
Because it doesn't seem to me that a patient would stay in the hospital that much longer, but the charge by the surgeon is dramatically larger.
So exactly right, and that so this essentially represents like the pilot part of the project, which is proving the model. Applying this model to then all that cost data, like 92% of the variability between that 1 level and the 3 level are directly related to surgeon choices in the operating
That's how you save money.
Yep.
Is you cut out all this multiple CPT codes. Just pay the surgeon just one flat fee, for doing the right thing.
Well, I would make the argument that in a lot of ways the surgeon is doing the right thing, right? I mean, there's a medical indication why the patient's having a 3-level fusion versus having a 1-level fusion.
Sometimes, not always.
Yeah.
Not always.
But so
In fact, I would argue it's exactly the opposite. I would say that in a large percentage, I wouldn't say a majority, but a large percentage of spine surgery done in this country, there is too much of an incentive to do another level. Ask a couple of our former residents who failed their boards recently.
Sure.
About that.
Yeah, absolutely. No, but I think it proves the importance of being incredibly judicious. And if anything, it's going to really even push people further to say, well, maybe it doesn't make sense to go big or go home. Let's stick with something small and something minimal until you can actually do the cost effectiveness analysis of say, well, okay, this subset of patients, we're actually going to do a prospective randomized trial and say, well, to avoid the development of adjacent segment degeneration disease, we're going to do that extra level versus these people that we've now, for cost reasons, have really started to minimize and just do a single level operation.
Most important thing about your study, I think, is the fact that you've been able to determine the cost, not the charges, but the cost for a whole variety of operations. The reason that, well, a lot of reasons that's important. One of the most important is that as we move, and we will move eventually from a fee-for-service to a bundled payment.
Yep.
If we don't know what our costs are, we are completely dead in the water.
Yep.
Now, let's give you a very brief example. I was a visiting professor a few years ago at University of Washington, and I always like to meet with the business people when I'm visiting and kind of find out how they do business. And one of their business people told me a story. They said that they were approached, they and Swedish, another big provider in the Seattle area, were approached by Boeing, one of the biggest employers in the Seattle area, and asked to give a bundled price for coronary artery bypass grafts. And both the University of Washington and Swedish said, okay, we'll get back to you. Well, before either of them could get back to Boeing, Boeing had already signed a contract with the Cleveland Clinic for bundled payment for a cabbage. Not because the Cleveland Clinic had an incredible price, it's because they had a price.
Yeah.
They knew exactly how much they needed to charge at a bundled fee to do a cabbage. Because they had all the data, they knew what the cost was, and they knew that this charge will be profitable, but not so egregious that nobody would sign the contract.
Sure.
Boeing knew exactly how much they had spent on coronary bypass grafts in the last 10 years. They did the math, they said, this is cheaper. So today, if you are a Boeing employee and you need a cabbage, you get on a jet, presumably a Boeing jet, with one family member, and you fly to Cleveland, you get your surgery, and fly back. And that just demonstrates the importance of knowing what your costs are. If somebody asks me today, we'd like to have a bundled payment for you to take care of some deep brain stimulation for Parkinson's disease, which we do a lot of. I wouldn't have the foggiest idea if the bundle price I was giving them was going to be highly profitable for us, or we're gonna lose our tail on it. And so that's what's so important about this, because there will come a day when we're gonna be told, when somebody comes in with neck and arm pain, here's $40,000 to take care of this patient. You guys, you wanna do 4 levels, you wanna put in plates and screws, you wanna use BMP, fine, have at it. You figure out how to divide up the $40,000 among the anesthesiologist, the hospital, the surgeon, the rep who's selling you all the instruments. It's gonna be a completely different game.
That's
I
what
think
Canada
it's-
does.
Huh?
That's what Canada does.
Yeah, exactly.
Here's your money for the year to do DBS surgery.
Right.
Whether you treat Parkinson's patients or do
Right.
brand new research indications for whatever you think and publish on it, and the Parkinson's patients have to go to the United States to get treated, that's up to you, but here's your money for the year.
So
Yeah,
that's why it's so important, and we really need to know what our costs are, and also figure out how to reduce them. But I suspect in spine surgery, the biggest driver are the CPT codes.
Yeah, no doubt about it. And I think that's part of the reason why, we're so excited about this project. I mean, really, despite the primary hypothesis being rejected, which was, the CSE model isn't necessarily better than the DRG model. And, admittedly, the hypothesis was sort of, post hoc hypothesis, just trying to, make sure that the research question was clear. But, really, at the end of the day, this gives us a way as surgeons to say, okay, how can I calculate exactly what this is? And then, now that I know what the cost is, in turn, how can I reduce it or how can I manage it?
The DRG is more relevant to a future of bundled payment. I mean, the DRG, Medicare tells you for DRG 1,
Mhm.
this is, the hospital gets $75,000 from Medicare.
Mhm.
That's what you get. And if you can manage that patient for $50,000, you've made a profit. If
Yeah.
it costs $125,000, you're stuck. So it's more like the future, whereas CPT codes are based upon our ability to negotiate with Aetna or whoever, Blue Cross Blue Shield, Medicare we don't negotiate with, we take what they tell us they're gonna give us.
Mhm.
So I think both of them have importance.
Oh, no, you're absolutely right. They both have a huge role. And
That's
I
how
guess,
we made so much money for the hospitals, is one of the highest paying DRGs in the country is a subarachnoid hemorrhage intubated. I think at one time was the highest DRG you could get. And so we did some cost analyses years ago when Owen first got hired, and looked at the outcomes of our patients and the cost of our patients before and after the development of a neurocritical care unit.
Yeah.
It was unbelievable, not only the quality of the care, when we quit taking care of them and let real doctors take care of them, but also the how much money we made for the hospital, because the DRG didn't change.
Yeah.
And we were admitting, 350 subarachnoid hemorrhages a year back then, and the hospital was getting a fortune off of them. And we were getting them out of the ICU, out of the hospital, early trachs, things that were good for the patients, but incredibly good for the hospital.
Yeah.
So it's really important data.
To me, the biggest factor after the years that I've been in practice and the investigative work that I do for the Department of Justice, the biggest factor is the rampant unethical abuse in decision-making. To me, is still amazing to this day.
Yeah.
The completely unnecessary spine surgery that takes place, or the overly excessive aggressiveness for somebody who has a more minor problem. It's out of control. I'd love to go to Medicare. I'd love to go to CMS and say, at age 58, I'm going to retire if you give me 0.001% of the fraud that I can uncover for you.
Yeah.
My golf game would get exceptionally good.
Well,
I don't know if I'm.
But it's almost every week in practice we see people, when you look at the X-ray of someone, you think, oh my God, I cannot
Yeah.
believe. And some of them are recent graduates here in the metro area.
So you referenced some people who are having issues with the boards, and just last week at the spine section meeting, Dr. Shaffrey gave a talk on what to do after you fail the boards, because apparently it's that big of an issue. And he showed one of the actual cases of one of the people that he examined who failed, and you would not believe it, a 12-year-old girl with a pars defect who has intermittent back pain only when playing on the playground at school. Saw her in the clinic. The mom, they have the information from the mom that said, patient was never examined, just seen in the clinic. Booked her for surgery, pars defects, 12 years old. Normal, healthy disc. They have all the imaging. 3-level ALIF with posterior perc screws. She developed a foot drop post-op day 1. She spent 2 weeks in the hospital. And then after discharge, the surgeon said, your family is too much for me to deal with. I want you to follow up with the university. Never saw her in follow-up. Lost the follow-up.
Dr. Rafai wants to interject for something here. Dr. Rafai, the floor is yours.
We could hear you taking a bath earlier.
I'm sorry. I muted it. Hang on. Go ahead.
Wait, can you hear me now?
Yes.
Okay, so Griffin, thanks for a great presentation. I think that to Dan Barrow's point, the biggest issue with us, kind of managing the spine center is it's not so much the CPTs as it is the choices that we make for what surgeries we do. In other words, if you look at the example of, let's say, an anterior lumbar fusion, there's 3 or 4 different ways to do it that's within the standard of care. And it's the choices that we make and the decision we make as far as which surgery for which patient that drives the cost. And then that drives what implants, what interbody spacers, what bone fusion devices you use. The problem with spine surgery is what Rusty said, there's too much variability. There's too many things that we consider quote unquote standard of care with poor data. The reason why we did this project was to reduce costs, and we actually have used this. You mentioned Swedish and you mentioned Seattle. We have taken this data and we've been in a contract with Walmart for the past probably 3 or 4 months, and we're actually meeting at the end of April with potential other employers, and I'm trying to get neurosurgery involved as well. But it takes time. But effectively, we have now come up with a bundle price for certain types of spine surgeries. The key is what we do is we create very strict criteria. You have to have certain BMIs. You have to have certain, hemoglobin A1Cs. And then we say, okay, for this kind of patient, we know the cost of care for this episode of an encounter for this surgery is going to be so much. So I think that the key thing is, Griffin was there at the spine section last week, but the stuff that we're doing at Emory with regards to the CPT codes, the DRGs, we're one of a handful of places, and we're much further along than where the rest of the country is when dealing with how we deal with spine care. Most people are still dealing with implant costs. We have resolved that issue 5 to 7 years ago. We're now actually at the forefront probably of how we're dealing with bundled care. And, with the new deal between Berkshire Hathaway's, JP Morgan and Amazon, large employers are skipping insurance companies and they want to negotiate directly with hospitals. And I think that's the key. What Dan was mentioning, this is the next level of medicine. We as physicians, especially as surgeons, need to be involved with this, because if you're not, you're going to have someone else in an administrative suite telling you how to do this, but they're not going to understand the kind of the nuances of medicine and kind of what the decision-making processes are. And this was a long process and long project that Griffin worked on, but it's been very, very productive and affecting the level of care that we provide to patients.
Rafai, you're going to be the guy in the administrative suite telling us all what to do. We know exactly what your aspirations are.
Well, I have to say, just sort of bringing it all back together, obviously I've really enjoyed working on this project, and just the MSCR experience as a whole has been amazing. And, I feel like in a year and a half, 2 years, I went from kind of a pretender, not really necessarily knowing how to actually do this stuff or even speak intelligently on it. And I'm certainly by no means an expert, but I actually feel like I've got a fighting chance to, step into the ring and be able to hold my own. On top of that, and this is just an aside for the residents, having a research year that you actually spend doing something that's research related as opposed to, just doing extra cases or, whatever it may be, really was a great personal and professional reset for me, and allowed me to do a lot of, I think, really important things that are going to be lifelong habits, like,
Lose 50 pounds.
lose 50 pounds and be around for the first year of my daughter's life, and some things that I will never ever be able to replicate. So that was just a wonderful opportunity, and also meeting people who are very smart and academic, but who are not clinicians, and seeing what that part of an academic career could be like. And so, in short, I could not recommend this experience more highly. And if you guys want to talk about it, I'm always available. And I'll end with that. Thank you.